Thank you. We're going to try to record this, I think. Okay. So thank you for inviting me. Can everybody hear me? Okay, good. Let me know if I start to kind of drift off. I have to hold this really close. So I'll be talking about the use of psychedelics in cluster headache. First, a couple disclosures. I do receive research funding from the Wallace Foundation, cluster headache, trigeminal autonomic cephalalgia, or CHTAC, and also ClusterBusters. I also receive research funding from Veterans Affairs. So today I thought I'd give some background about cluster headaches, since this is a topic which I think many of you may not know that much about, and then also talk about psychedelics in cluster headache, give some context of the neurobiological associations between the two, and talk about some ongoing research, that's actively going on. So cluster headache is a type of headache under the umbrella of the trigeminal autonomic cephalalgias, or TACs. These include 5 different headache types. Cluster headache is the most common one of those. Paroxysmal hemicrania, hemicrania continua, Sanct and Suna are very rare headache types, but cluster headache is the most common one of these. And these all involve pain in the first division of the trigeminal nerve, shown here in this picture. And the first division goes right into the eye. So these types of headache tend to focus right behind the eye and tend to be exquisitely painful. So much more painful than a tension headache or a migraine headache. And thankfully, they're not very common for how painful they are. The defining feature of cluster headache is the headache itself, which is called the cluster attack. This is a photo from an early publication. I think they didn't have Photoshop back then, but they somehow made the face really droopy, which is a bit of an exaggeration, but what happens during a cluster attack is there's pain on one side of the face, and it's usually right behind the eye or somewhere around the eye, and then there are these autonomic features. So drooping of the eyelid, sweating, drooping of the face, again, this is kind of exaggerated here, also nasal stuffiness, lacrimation as well. And as an opposite of migraine, where people tend to want to lie down in a dark room and be still, during a cluster attack, people get really agitated. They start pacing back and forth, probably in part because the pain is so severe. They're trying to sometimes distract themselves from the pain. So cluster attack is relatively short. It's only about 15 minutes up to 3 hours, the average being about 1 hour long or so, which doesn't sound very long, but it's very long because it's very painful. The other thing is that cluster attacks can happen up to 8 times a day, and that's for the official definition, but I've met people who have 10, 11, 12 attacks a day. So they're short headaches, but exquisitely painful, and they can happen multiple times a day. There are people who have these headaches year-round. They have the unfortunate diagnosis of a chronic cluster headache, and then there are those who have cycles every year or every couple of years where their headaches will come for a few weeks or a few months at a time, and then they go away. And during those couple of weeks, a couple of months, they're very debilitated, they can't do anything, they kind of stay home, they can't work anymore, and then their lives go back to normal. The chronic cluster headache, thankfully, is less common. It's about 10 to 15% of the total cluster headache population. They suffer a lot because they're in this state all the time. This is a cluster headache diary of a patient, of a former mentor of mine. Here they plot one of their cycles. So each one of these is a day. Let me do this with my right hand. And then this is the time. And they got their AMs and PMs mixed up, but in general, they made a box for every cluster attack, and how tall the box is how long the attack was, and the color was how intense it was. So the more intense headaches were the reds and the blacks, and the less intense headaches were the blues and the greens. So the cycle starts off with a couple of not so intense ones, and then they ramp up, having multiple attacks a day, getting more intense, and then it kind of fades off and the cycle ends. So the headaches start, and then they stay, and then they suddenly go away. And one of the reasons it's called cluster headache is because the attacks tend to happen around the same time every day. So you see on this diary, it tends to happen around like the evening time. And that's not uncommon. It tends to happen in the evenings and also overnight. These headaches tend to wake people up from their sleep. So on top of being in a lot of pain, they don't sleep very much. Just a little side note about what exactly we're talking about when we talk about headache. Everyone kind of knows what a headache is, but I want to give sort of some context to that. So there are a couple of nerves in your head and your face and neck that can feel pain, and that also make some of these other associated symptoms like the drooping and the nasal congestion. And those are the trigeminal nerve, this purple one, the occipital nerve, and then these are the parasympathetic fibers that are coming in, causing the lid drooping and the face drooping. And they all live in the brainstem, and they all go up into higher brain levels, the thalamus, the hypothalamus, the thalamus, all the way up to the cortex where you perceive it. And this is a picture from a migraine. We're talking about migraine, but a lot of the same areas of the brain, they are involved with cluster headache as well. And these areas of the brain have been mapped out, and there's certain surgeries that can be done targeting different brain areas, treating headaches, and so this is a pretty well mapped out system, although we still have a lot to learn. So one of the areas that's on that larger picture is the hypothalamus, and in cluster headache, the posterior region of the hypothalamus lights up during a headache, and when patients are in cycle. So when they're out of cycle, when they're not having the attacks, their hypothalamus looks normal. But then when they go into cycle, and especially during an attack, their posterior hypothalamus lights up. That happens to some degree in migraine headache as well, but it's a very strong association in cluster headache. Some other factors that are involved with cluster headache are different hormones. So levels of cortisol, prolactin, testosterone, melatonin, which is a sleep hormone, they're abnormal in patients who have cluster headache, both in cycle and also outside of cycle. Certain genes have been associated with cluster headache as well. They haven't really nailed down any one gene that seems to be responsible, and there's probably not going to be just one. Just like in migraine headache, there are many, many ways that you can get to migraine headache. And also inflammation is involved. So CGRP, TNF-alpha. Have you guys heard of the new CGRP treatments for migraine headache? It's a once-a-month injection, and it's targeting calcitonin gene-related peptide, or CGRP, which is involved with neuroinflammation. And one of these new drugs is approved for cluster headache. So these are all some either neuroanatomical or some biological correlates to cluster headache. Going back to cluster headache itself, I talked about how it's somewhat rare, but it's not that rare. It's somewhere from 1 in 1,000 to 1 in 5,000 people. It tends to be more males than females, but that number is kind of shrinking because females tend to be diagnosed as having migraine headache, and so a lot more females are now being recognized as actually having cluster headache. But it is a more male-heavy disease. As I mentioned, having the severely painful headaches multiple times a day causes a lot of problems in people's lives in terms of not being able to work, relationship issues, having to apply for disability. And starting back in the 50s, patients started to call this headache suicide headache. There is some work out there about suicidal ideation during cluster attacks, but also outside of attacks themselves. Patients not wanting to end their lives because they don't like themselves, but because if they can end their lives, they can end the pain. So it's complex, but suicide headache is a poignant nickname. This is a one-page article from several years ago. This is a case report of a patient with cluster headache who shot himself in the head during a cluster attack. And these are the scout images of the CAT scan showing all the bullet fragments throughout. And it says both intracranial and extracranial, but I think a lot of it must have been extracranial because it also says that he survived and was discharged with no neurological deficits. This is not the only case of this. Patients, if they haven't actually shot themselves, they have not uncommonly found themselves holding a gun to their head because they want the pain to stop. Patients have stabbed their eye with a knife, with a spoon, with different implements to stop the pain. So it is very severe. There was a survey that was done not long ago asking people who have cluster headache who have also experienced other painful things like kidney stones or childbirth, and to rank how do you rank on a scale from 1 to 10? And on average, the pain from a cluster attack is around a 9.5, and childbirth and kidney stone and gunshot wound were around a 7 or so. So people who have experienced multiple types of different painful things will universally rank cluster attacks as being more painful. There are some treatments out there for cluster headache. Just like with any headache disorder, you want a good medication to stop an attack when you get it, but also try to prevent them from happening in the first place. So there are two good medications to abort attacks, which is 100% oxygen inhaled through a non-rebreather mask, and then also sumatriptan injected under the skin. You can only inject sumatriptan up to twice a day, really, which is not useful if patients have 8 or 9 attacks a day. Inhaled oxygen you can use as often as you need, but most insurances don't cover it, unfortunately. To prevent attacks, verapamil, which is also a blood pressure medication, is commonly used, but it causes a lot of constipation. It can cause something called heart block, where the top and bottom of your heart don't talk to each other anymore, so it makes you faint. Lithium is actually pretty decent, but has a lot of toxicity itself. People try different anti-seizure drugs like Topamax or gabapentin, but they're not very effective. And then people may be put on a course of steroids for a couple of weeks, which temporarily helps. None of these is really 100% effective in patients. And I mentioned the new CGRP drug, alkemezimab, which is a once-a-month injection, but that's only approved for patients who have an episodic form of cluster headache. So for people who have chronic cluster headache, it doesn't seem to help that much. You can get nerve blocks where an anesthetic with some steroids is injected near the nerves to try to desensitize them. This device, sphenopalatine ganglion stimulator, is no longer available. The company that actually made it went under. So there are some people who still have this thing implanted in their faces that for some patients it was helpful during attacks, but we're not really sure where it's going to go now that the company is under. And then there is another device, the vagal nerve stimulator, which is a remote that you hold by your vagus nerve, and that can help stop attacks during an attack, and also, if used on a daily basis, can also prevent attacks. But it's not 100% for all people. And then last resort, deep brain stimulation. So people have targeted the posterior hypothalamus, that region that lights up, with the deep brain stimulator, and it can help some people, but it has a high morbidity rate, infections of the leaves. There's been deaths as well. So there are options out there, but not always great. And these 3 are the only ones that are FDA approved. So some insurance companies won't cover some of the other choices. One of the other areas I'm working on is trying to get inhaled oxygen recognized as a treatment, because even with the best preventive medication, you're going to have some attacks break through. So to have a really good medication for when the attacks happen is important. And it's kind of shameful that oxygen is not available. So of all these things, only 3 are actually approved. And the vagal nerve stimulator costs $600 a month. So most people can't really afford that. These are just a couple quotes from some patients when asked what do you do during an attack, medication-wise or otherwise, from a survey. So one patient takes sumatriptan, but if it doesn't help, they pray for death. Another one will try to create another type of pain to try to distract himself, so he'll push a needle through his skin. And some people say that that really helps. They'll punch their hand against the wall, they'll hit their head against the wall. I've met patients who have actually broken their own fingers to try to actually distract from the pain. And then from the same survey, these are a couple of quotes from people who have tried psilocybin mushrooms. The first one has tried multiple preventatives for 36 years. Most made him sicker without really much benefit, and he's been trying psilocybin, and so far it's the only thing that's helped him. The other one, a person pretty clearly says that psilocybin has changed their life. They can go to work, they can support their family. So this same headache diary that I showed you, this patient had cycles every 2 years. So his next cycle in 2003, he first tried a low dose of psilocybin mushroom and found that his severe attacks, the reds and the blacks, went down to the blues and the greens for a couple days. They started to come back, so he took a pretty big dose of psilocybin mushroom, and they went away. So if you're counting from when he took the first dose, it took so he took 2 doses in about a week, and his cycle ended early. His 2-month cycle essentially was done. So there's really not much that can do that, and these steroids can break a cycle, but you have to be on the steroids while it's happening. Nothing you can take once or twice and have such a profound effect. That's what makes this very interesting. So now I come to the next part of the talk, psychedelics in cluster headache. So that was just one example, but there are case reports, surveys in different languages, even buried in other articles. This one was about verapamil and gingival enlargement, of patients taking psilocybin mushrooms, LSD, and reporting long-term effects. They may also take the drug during a cluster cluster attack and say that it helps that one attack, but that's not as interesting as it having such a long-term effect on ending a cycle or breaking someone from chronic into episodic. Or I've met a couple people who have taken it and who've never had an attack again after many, many years. So this is the ClusterBusters group. This is just a handful of some of the ClusterBuster folks. This is a patient advocacy group that was started up by Bob Wold. He's somewhere in here. He's a cluster headache sufferer, and he back in the early 2000s set up ClusterBusters, and this started after there had already been some talk online about LSD and psilocybin helping. They would take a couple of doses over the course of a week or two, and then bust their cycle or bring them out of chronic cluster headache, hence the term ClusterBusters. They're the ones who did one of these surveys that I analyzed a couple years ago, and showed that when compared to other preventive cluster headache medications, the most commonly used ones like verapamil over here, the kind of medium used ones like propranolol here, and the less commonly used ones like LSD or DMT, psilocybin was kind of here, that the more effective ones were the psychedelics. So on this graph, the efficacy is converted to 100%, where the completely and moderately effective are the darker bars. So the more dark is the better, is more effective. So standing way back, you can see that the bars that have more dark is the psilocybin, the LSA, lysergic acid amide, which is a compound in the seeds of certain plants, like the morning glory flower, LSD, and then DMT over here, or the most effective. BOL here on the end is an LSD molecule with a bromide attached to it. When the bromide is added, it makes the compound very minimally psychedelic. So still a little bit of fogginess or haziness, but not the classic psychedelic experience. So in a case series of 5 subjects who had cluster headache, they took BOL in the same three doses a couple of days apart, like the ClusterBuster folks do, and their number of weekly attacks went down dramatically. In some patients, out to 3 months, they weren't having any more attacks. So there's another minimally or less psychedelic compound in the same class, 5-MeO-DALT, or just called DALT by those who use it, where after a single dose they can have up to 2 weeks without any headaches. And in case reports and in surveys, patients report using very low doses of psychedelic mushrooms and of LSD to help manage their cluster headache. The doses of the psilocybin mushroom ranging from 0.1 gram, which is almost nothing, up to 5 grams, which is a very whopping dose. But a lot of people did use these sub-hallucinogenic doses to manage their headache disorder. And then here, a couple of patients used sub-hallucinogenic LSD to also get a couple of weeks of relief. So putting this together, it would seem like the psychotropic effects of psilocybin and LSD and similar compounds doesn't seem to be necessary for the treatment, which is a little different from how psychedelics have been used in medicine so far. But it's important to note, especially with these compounds like the BOL and the low doses. So just as a little tangent here, I know that there are some folks who I invited who maybe haven't heard too much talk about psychedelics, so I just want to step back and also talk about what I mean when I say psychedelics. And what I mean is compounds that bind the serotonin 2A receptor and that cause change in your perceptions and your sensorium, such as LSD and psilocybin and DMT. What I don't mean, and what patients don't report success for cluster headache, are the empathogens like MDMA, which is an amphetamine and which causes serotonin release. It doesn't have a significant 2A receptor binding profile. The dissociatives like ketamine and PCP are antagonists at NMDA receptors, very different pharmacology. Ketamine is used to manage headache disorders, both migraine and also cluster, but doesn't have the same long-lasting effect that the psychedelics do. And then cannabinoids, which patients may use to help with anxiety or sleep problems during their cycles, but that doesn't seem to really help the actual cluster disease itself. So when I say psychedelics, I mean the classic serotonin 2A binding compounds and their congeners like the BOL or the 5-MeO-DALT. And then just some more background, the psychedelics, the classic psychedelics, are broken up into the indolamines and the phenethylamines. The indolamines contain the tryptamines and the ergolines. The tryptamines are the DMT, psilocybin, 5-methoxy-DMT, the more common ones. DMT is on the sticky stuff on toads. Hugo talked about licking toads, and so that's from. The ergolines contain LSD, and there's Dr. Hoffman, who created LSD when looking for a treatment for migraine headache. And also LSA, which grows out in your front yard. In morning glory flowers, it's in the seeds, and some other similar plants. The phenethylamines, the most commonly known one is mescaline. These are more amphetamine-like, they're more like dopamine, whereas the indolamines are more like serotonin. So mescaline, I've met a few people with cluster headache who say that mescaline helps, but largely not as much as the others. And then some other phenethylamines are these substituted amphetamines that are used mainly in research when studying the serotonin 2A receptor, but they're also psychedelic. But I have not heard of people using them for treating cluster headache. And I know it's kind of bright here, but I wanted to also demonstrate that, as I mentioned, LSD was first created when looking for migraine treatment, and there's LSD and psilocybin there. Psilocybin chemically looks similar to melatonin, which, as I mentioned before, is a hormone that's abnormal in patients who have cluster headache, and it's also structurally similar to sumatriptan. They're all indolamines. There's the indole ring and the amine. Those are all similar. LSD is ergotamine, which is, and some other ergotamines are methysergide and DHE, which are also used to treat headache disorders, including cluster headache. DHE is not uncommonly used for managing severe migraine and also cluster headache. People come to the hospital and actually get DHE through the IV to really quiet down the headaches. And at a high enough dose, you can start to feel a little funny, not exactly psychedelic, but it can have psychotropic effects. And the ergotamines, they're actually, they can be found on the grains that have a fungus on them. The fungus makes the ergotamine, or it makes the ergots. And when people consumed too much of these tainted grains, they got something called St. Anthony's fire, where they had ergotism, so the venoconstriction that happens on the outside of the body, causing the veins to close up and causing skin necrosis. But if enough of it gets into your brain, then they also had a psychosis. So this was called St. Anthony's fire, and he's having a bad trip. So there's some historical context. At a high enough dose, compounds in this class in general can all create some sort of psychotropic effects. Some more neuropharmacology. This is a very oversimplified serotonin neurotransmission. This is not what it looks like in real life, but this is just oversimplified just to show that the triptans that are used to treat cluster and also migraine, they're acting on serotonin 1B and 1D. The tricyclics that are also used to treat migraine and are used sometimes in cluster but not very effective. They also bind serotonin 2A, and they're also SSRIs. Psychedelics and other indolamines like methysergide or DHE that are not classically thought of as psychedelics, but at a high enough dose might be. They all work on serotonin 2A. So all of these medications that are used to manage headache disorders are all working on the same system. So it's not outside of the realm of possibility that psilocybin or LSD could have anti-headache effects, because the drugs that are like it work on the same receptor, and then drugs that also help headache are working in the same system. So here's that picture again. That again, this was from a migraine review, but showing that there are several areas of the brain that have been identified to be important in cluster headache. One of those, again, this is the same picture. The posterior hypothalamus lighting up during an attack or in cycle. So has anyone looked at what psychedelics do to this brain region? And of course the answer is yes. In rats, psilocybin activated the area of the brain containing the hypothalamus. And in humans, I'll just summarize what this showed, but in these functional neuroimaging studies, there was actually decreased activity in those areas. And again, this is just what happens acutely when the drug is actively there in the brain. How that translates to a long-term effect is still not known. But it just demonstrates that there is something happening in that brain region when the drug is given. Also looking at, these were rat tissue, so the tissue from the hypothalamus. This, again, these are some older studies, going back to 75 even, looking LSD reduced activity in this one study, And then when LSD was given chronically, it increased the neurosecretory material inside these different tissues. So again, these are older studies. They weren't specifically looking to see whether psychedelics would help headache, but just showing that they are having activity in the brain regions known to be not to be pathologic in cluster headache. I mentioned that melatonin levels are low in cluster. So this is a graph averaging over the course of the day melatonin release in the average population and then in the cluster population. The cluster population is lower, and also the peak is a little early. It happens a little bit earlier. So the release of melatonin is blunted and phase advanced in patients who have cluster headache. So what do psychedelics do to melatonin? Well, in this pineal tissue, melatonin is made in the pineal gland. In this pineal tissue from rats, mescaline, psilocybin, and LSD, they all cause melatonin release from the pineal tissue. Again, this was not in vivo. This was in a dish. And again, this is and looking back in 1971. There's not much out there, but if you look, there is some evidence that these drugs are working on the systems that are involved with cluster headache. But we need some updated material. I mentioned that a lot of cluster attacks happen during sleep. So this is a polysomnogram showing over the course of the night the patient's sleep in wakefulness and then deep sleep. And each one of these arrows is a cluster attack. So he's being woken up every couple of hours with a cluster attack. Sometimes it happens out of deep sleep, sometimes it happens out of REM sleep. These dark bars are the REM sleep. And it seems like cluster attacks tend to happen out of REM sleep for a lot of patients. There have been some more recent studies looking at the sleep architecture in patients who have cluster headache. And they tend to have less REM, although that's not universally seen in all studies. In those patients who have had deep brain stimulation for their cluster headache, they do have some sleep architecture correction after deep brain stimulation. But I wouldn't go so far as having DBS placed just to help my sleep. But it would help cluster headache in those patients too. And then there have been a couple of studies looking at the effects of sleep after psychedelics. They weren't specifically sleep studies, but it was mentioned and their sleep was also improved in a couple of patients when they were given LSD, and these were in high doses. They had increased REM for up to 3 nights after a single dose. And then another study that was done looking at anxiety in patients who had cancer, a single dose improved subjective sleep for up to 10 days after a single dose. And in rats, LSD and also BOL, this non-psychedelic congener of LSD, delayed the onset and increased REM, decreased REM, which is the opposite of what you would want in cluster. But again, these are rats. They're a little bit different. But again, this is going back to the 1970s. So when you really dig, there's evidence out there that these drugs are having effects on these systems. But we need some really updated material to really show that. So now to touch on some ongoing research. So this picture, I'm not sure where it came from exactly, and it's largely suspected that this is Dr. Andrew Sewell, who was part of the psychiatry department. He unfortunately passed away a couple of years ago, and he was the main reason I came to Yale. And of course, Dr. Goshawk was in the audience. So. But Dr. Sewell has, he first introduced me to the ClusterBusters group. He'd been interested in psychedelics for a long time. I studied psychedelics back in grad school, so in looking up the latest, I saw that there's this headache research that's starting, and I really like headache disorders, so I thought this was the perfect match. So Dr. Sewell had I've been working closely with the ClusterBusters group, learning what their regimen was, their busting regimen, and was setting up to do a study when he unfortunately passed. So it was right around the time when I started here. So with the help of Dr. Goshak and with Dr. D'Souza at the VA, who was also Dr. Sewell's mentor, we got it up and running. This cartoon is showing how he's talking about LSD, stopping clusters. It's been an uphill battle, and here's the DEA man who's not looking too happy. He has a lot of pagers here. When this study started, it was there had already been a couple of the studies out of Hopkins at NYU, so the concept wasn't so radical. So the FDA and the DEA and the multiple IRBs that we had to go through didn't give us too much of a hard time. So it wasn't as bad as this cartoon made us think it was going to be. So that's everybody who was involved in getting the study up and running. After starting looking at patients with cluster headache, we decided to also look at migraine headache, and also because I work at a VA hospital, there's a lot of post-traumatic headache, so patients who develop headache after a head injury. So I'm also looking at migraine headache and post-traumatic headache as well. The funding comes through CHTAC, as I mentioned. It was initially through the Hefter Research Institute, which also funded a lot of the other psychedelic research that's been going on. The Wallace Research Foundation is a private group that has recently had an interest in funding psychedelic research. Then, of course, the psychiatry funds for some of the costs. And just to briefly talk about how the design is laid out, a lot of this was borrowed from what ClusterBusters had sort of developed over the years. Patients get 3 doses about 5 days apart each, so these number days can be variable. They keep a headache diary before, during, and a couple months after, and then we have a couple follow-ups. They're randomized to get either placebo or a lower dose or a higher dose of the psilocybin. So this is almost completed. We're still ongoing with this study. So I'm not going to talk about results right now, but I will be able to in the near future. So this is sort of how the study is ongoing. The migraine and the post-traumatic headache study are a little bit different. The migraine study, it is complete, and I'm working on the final data analysis for that. So I'm very excited about that. So unfortunately, I won't talk about study results here, but these are the basics of what we're doing. So in summary, cluster headache is very debilitating, as I showed, and there are treatments out there, but they have a lot of side effects. They can be expensive. Insurance companies not covering them. Patients with cluster headache have found that psychedelics offer something new. A couple of doses giving a long-term effect with relatively minimal side effects. And it seems like because low doses can help and because non-psychedelic congeners also can be helpful, that the psychedelic effects seem to be separate from the treatment effect in cluster headache. There are certain biological areas that we know are affected by cluster headache that psychedelics act on. So theoretically, some whatever mechanism is ultimately responsible for this long-term effect may be acting through one of those, systems, or multiple, or more than one of those systems. And currently, there's a trial ongoing, nearing completion, as the first randomized control trial, which patients have already reported this since the early 90s. This has been helping, but the scientific community will not accept it until there's a randomized control trial. So that's ongoing and almost done. If anyone wants my references, especially my 1960s sleep and references. And then these are some of the people to thank for getting the study started, funded, and ongoing. So thank you. I'll take any questions. Yes.
I guess it's a couple super short ones before the real one. Is inflammation seen in 100% of cluster patients?
Sorry?
Is inflammation seen in 100% of cluster patients?
Well, we don't really, I mean, we don't really measure it. But yes, in the trials where they, when they were first developing all these anti-CGRP drugs, they would measure CGRP levels during attacks, and they would give people cluster attacks by giving them alcohol or giving them nitroglycerin, and the CGRP levels go up. So, and so yes, inflammation is and for migraine as well, yeah.
And I guess, do you have any speculation on psilocybin's effect on sort of immune regulation, either acutely or chronically?
Yeah, so there's a lot out there that that's been coming out about what the anti-inflammatory effects. Yes, so that is certainly possible. That there's also anti-inflammatory actions. What's being reported right now are the acute effects, and so there's nothing about whether these drugs reduce CGRP levels. I'm starting to look at that in the migraine and post-traumatic headache studies that I'm doing. But in terms of long-term effects, there's nothing out there yet. But that's something that I would like to look at.
Is there any evidence to suggest that psychedelic effects may have additive effects towards the therapeutic benefits of any of these psychedelics in cluster headache?
Yeah, so it's hard to separate out because when their headaches go away, they always feel better. But so far, in what I've heard is that patients for whom the psychedelics work somewhat, but not all the way. So they may be, instead of attacks every day, they get an attack every few days, which is a huge improvement. They feel like they're not as anxious about their next attack, and so I have heard of some additive effects where they don't feel so worried about their condition, about the next attack, which is very commonly they're very anxious about their next attack. So yes, possibly.
Is there any anecdotal information about ayahuasca?
Yes. So in general, when I've heard patients who've done ayahuasca or DMT, it has generally a short-term effect because it is metabolized so quickly and the effect is so short. I haven't heard of it having a long-term effect. So whether the compound has to hang around a certain amount of time for it to do its thing, whether it's on the hypothalamus or on CGRP or on something else, it would seem like it has to be in there for some time to have the long-term effect. But patients do use DMT to stop one single attack at a time, but you can't do DMT every time you have an attack 5-6 times a day. So short-term, but probably not long-term effect. If there was a way that we could keep, so with the ayahuasca, that keeps the DMT around longer, but I haven't heard it have the same long-term success rate.
What did you all use as a placebo control in the trial that you?
Yeah, so that's a great question because so obviously controlling for psychedelic effects is very difficult. Plus, a lot of the possible control substances, like if we use an antihistamine or if we used a benzo, can also have effects on patients' headaches. And so we actually use cellulose as the control, but the lower dose that we're using is sub hallucinogenic, and so patients wouldn't be able to know whether they got the placebo or the lower dose. So it is very hard to completely blind people in psychedelic studies. From here, we would like to start using some more active controls, even ones that are known to have short-term but not long-term headache effects, like possibly ketamine.
at that lower dose, the participants don't really notice that they have any like changes in sensorium or?
So we're still blinded at this point, but just from like experience, just from working with the migraine study, you're working with all the studies, I suspect that some patients who might have gotten placebo might think that they've gotten drug. So there is a lot of expectancy. There's of course a lot of hype around psychedelics, and so people may feel effects when there's no drug there. So it goes both ways. Yeah, it's complicated. From here, then we can design studies where we take that more into account.
Will there be opportunities for those patients that didn't get the active to then do an open label?
Yeah, so we're actually in the phase where we're having patients who are still able to, who still qualify for the study. They can come back and they'll either get the lower or the higher dose. So yeah, everybody can have the opportunity to come back and get one of the doses.
Are there any medical comorbidities associated with cluster headache that are related to inflammation that are commonly seen? One comorbidity
would be there is a higher rate of patients having sleep apnea with cluster headache. Sleep apnea in general creates a lot of inflammation, a lot of stress on the heart and the lungs, and that in turn leads to inflammation. And what's interesting is that some patients who treat their sleep apnea, they have dramatically reduced number of attacks. It may not be completely cured, but it can help them. Cluster headache patients tend to be heavy smokers, so that of course leads to inflammation in general. But it seems like that smoking doesn't cause cluster headache or make it better or worse. It's just a personality trait that tends to happen. In a survey that I analyzed, I found that patients who smoked or who smoked before but had quit had a better response to oxygen therapy. Which I don't know what that means exactly, because it was even seen in patients who used to smoke and didn't smoke anymore. So their higher hemoglobin levels would have gone back down to normal. So I can't say that's the reason why. Yeah, but in general, cluster headache patients tend to be pretty healthy. Yeah.
Are there any studies showing that melatonin or melatonin or anything help?
Yeah. So patients who take melatonin every night, there was one study showing that it was helpful actually reducing burden over time. Yeah. So I'll often patients who have tried a lot of the pharmaceuticals and don't want to try them again, or had too many side effects, I'll try melatonin. It's not. I haven't had as much of the success as the earlier study did, but if anything, it might help a little bit.
Anecdotally, people at these ClusterBusters meetings will endorse taking extraordinarily high doses of melatonin, 30 milligrams or more, and will say that they have eliminated their nocturnal attacks, etc. So I think there's good reason to consider a dose ranging study of that at some point.
Yeah. Patients also take very high vitamin D doses, so they'll take 50,000 international units for like a week, and then they'll go down to 10,000, and then they'll stay on 5,000 for some time. So very high doses of vitamin D, sometimes combined with another vitamin regimen, including magnesium and boron and a couple of others. Some patients have found that to be helpful as well. So that also speaks to the anti-inflammatory component in the immune system as well. That there's nothing that works for everybody. I've even met patients who've tried busting with mushrooms, busting with LSD, ayahuasca, and it hasn't helped them. So.
I was just wondering if there's a typical age of onset for your first cluster headache, and similar to your question, if it kind of coincides pre or post with any other psychopathology?
Yeah. So for cluster headache, it can there's a wide range. It can start in childhood, and it can start in like your 60s as well. It tends to start a little older than for migraine headaches. So So like 20s, 30s. I've not uncommonly met people who start having attacks in their 40s and 50s. There's kind of like a bimodal peak. In general, cluster headache tends to get better as you age, so that brings in the hormonal system again. Some patients treat themselves with testosterone as well as a treatment for cluster headache. And in terms of psychopathology, there as like with migraine headache, there is an association with other mental health disorders. I don't know if it's been parsed out whether it's because of the chronic pain or whether in those whom cluster headache started later in life, if they already had. I'm actually not sure. I don't know if that's been looked at very carefully.
Has there been any research associating any increase in attack frequency around menopause in women?
So for migraine headache, there's a lot out there about patients having worse attacks during the menstrual cycle. So yes, that can happen in cluster. What I've heard in a handful of patients is that their cluster headache tends to get better during pregnancy. We polled the room once at a ClusterBusters meeting, because you'll never have that many people with cluster in the same room at the same time. And those who have been pregnant said that they either went the whole year without attacks or very minimal. So again, the hormones must be involved in some way. Great, thank you.
Yeah, you got it.
That really speaks to